This is Caden, a 7-year-old male castrated Rhodesian Ridgeback. He presented for straining to urinate and defecate for 1 week. He had a history of urinary incontinence for the past several months, which had been worsening, and a history of prostatitis from several years prior. Just to review the anatomy of the prostate gland, on the left of the image is the urinary bladder. The apex is towards the left, and the trigone is to the right, or the caudal aspect of the urinary bladder. Caudal to the urinary bladder is the prostate gland. If you remember, the urethra will extend from the urinary bladder and through the prostate gland. And so in the next video that we're going to see, the dog is going to be positioned much like this. The head is going to be to the left, the tail is going to be to the right, and we're going to start on the urinary bladder. And as we move caudally in the dog, we'll start to see the prostate gland come in. In a neutered dog, the prostate gland is normally very small and well defined. In intact male dogs, the prostate gland can be much larger. So again, just to orient you, the dog's head is to the left, the tail is to the right, the urinary bladder is to the left, and the prostate gland is to the right. So as the video starts here, we're going to be looking at the urinary bladder. Deep to the bladder is the aorta, and we're at the level of the trifurcation, which we can see right there. And this is the level of the medial iliac lymph node. So just to the left of the aorta is that hypoechoic round structure. That's a medial iliac lymph node, which is too large. It's slightly more hypoechoic than it should be as well. So in long, there's the aorta, and in the near field there is a medial iliac lymph node, which again is too large and hypoechoic. As we go caudally, there's the trigone of the bladder to the prostate gland. The prostate gland is enlarged here. It should be a small and well-defined structure with a very homogeneous parenchyma. We can see that the parenchyma in this prostate gland has some very hypoechoic to even anechoic cavitary regions. And there's also that hyperechoic region, which is probably secondary to his history of prostatitis. He had a prior marsupialization. Now in the transverse plane, looking through the prostate, we can see again those areas of anechoic fluid, several of them which are well defined as we move caudally on the prostate gland. And so again, this prostate gland is too large and should be much more homogeneous and definitely shouldn't have these areas of cavitation. There's a nice look at the bladder going right into the prostate gland. Again, we can see the large cavitary regions within the gland itself. And so what we're doing in this video is we're now sampling the prostate gland in hopes of getting a diagnosis. And so we're using ultrasound-guided aspirates, and so the dotted line on your screen is the guide, and so that's what allows us to guide the needle into the correct location. You can see on the left there's a needle that's just been placed into the guide. We have color Doppler on just to make sure that we're not going to be going through any large vessels, and we're going to see the needle come through right there, right in the region of the guide, and so that's why we use the guide to make sure we're hitting the exact location that we want. Once the needle's in place, we go ahead and remove the stylet and attach a T-set with a syringe. And we go ahead and suction the fluid from the anechoic regions of the prostate gland. And so we can see on the left of the screen that fluid is sort of a yellow-greenish color, consistent with abscess fluid. The primary differentials to consider when identifying a prostatic mass on ultrasound include abscess, neoplasia, most commonly carcinoma, adenocarcinoma, or transitional cell carcinoma, a cyst, or granulomas. In this case, abscess was the most likely differential given the anechoic fluid-filled regions and then the additional confirmation based on aspiration of the fluid. Prostatic abscesses develop as a result of bacterial contamination that spreads from another part of the urinary tract by hematogenous route or from cysts that can become secondarily infected. Clinical signs of prostatic abscesses result from compression of adjacent structures due to prostatic enlargement or from complications related to local or systemic bacterial infection. Common clinical signs that are seen in dogs with prostatic abscesses include dysuria, stranguria, purulent or hemorrhagic penile discharge, tenesmus, ribbon-like feces, as well as pain, pyrexia, sepsis, and even shock. There are multiple different Treatment options: there's surgical treatment for prostatic abscesses, which would include debridement, endometralization, or marsupialization. There's also been subtotal prostatectomies and Penrose drains, which can be placed into the prostate gland. Both of those have also been performed on prostatic abscesses. These can be associated with postoperative complications such as urinary incontinence, peritonitis, reabscessation, and of course the complications that are typically associated with surgery. There's also percutaneous drainage of the prostate gland. There are not that many reports out there describing percutaneous drainage as a primary means of correcting the abscesses, but there are several small reports in small numbers of dogs which describe successful drainage of prostatic abscesses that didn't require any follow-up surgery. So at this point, both of those treatment options are available.